So an overview of the ED management goals. And I want to emphasize that these goals that we put down there are very different than what currently happens now. What currently happens in emergency departments around the province is that if a patient presents with an acute, possibly life-threatening complication of their opiate use, such as overdose or suicidal ideation or sepsis or whatever, and they're stabilized and treated, and they're sent home, or maybe to the withdrawal management center, with nothing, with no involvement or long-term treatment. And that's partly the system doesn't offer or provide any immediate treatment for opiate addiction, or any addiction for that matter. Totally different than if they presented with heart failure and they're stabilized and then sent home. They'd be seeing a specialist right away and then back to the family doctor. That care pathway doesn't happen in the emergency departments or in the general healthcare system now. You have two completely separate systems, the addiction and the healthcare system, and it's not good for patients. So what we want to do is to change that. I'm going to go over this really quickly. There's lots of slides. It's very hard sometimes to identify an opiate use disorder because the patient may want opiates from the doctor, so they're not going to disclose their use. I think the most important is to be familiar with these common presentations of opiate use disorder, which includes overdose, withdrawal, drug seeking, infections, depression, suicidal ideation, and trauma. And as long as you're alert to that, then you're on the road. Treating opiate overdose, I'm not going to go into the main protocols other than to mention that you do need, of course, a period of at least 6 hours after the overdose without respiratory support, without naloxone, before you can safely discharge a patient, and 10 hours if it's a methadone overdose. The most sensitive indicator of toxicity is not like loss of consciousness or anything. It's actually, you need to engage the patient in speech for a few minutes, and if they're nodding off, that means that they still have opiate toxicity. They still have opiates on board, and they're still at risk for an overdose if they go home and fall asleep. We are going to recommend the use of buprenorphine in the emergency as a treatment for opiate withdrawal, regardless of the presentation. So what we're saying is that you'll use buprenorphine if the patient is in withdrawal after the naloxone is discontinued. And you should not use opiates in the emergency department for an opiate-addicted patient. There's no need to. Buprenorphine is an opiate. It's more effective in treating long-term withdrawal and long-term management. So now we'll get into opiate withdrawal. You've all heard that opiate withdrawal is a benign syndrome. That's actually not true. Opiate withdrawal is associated with a significant increase in death from two sources. One is suicide, and that happens when a patient is in withdrawal, especially if they can't get access to opiates. And the other is, ironically, overdose. So typically a patients who have stopped using opiates, maybe because they're in hospital or whatever, or withdrawal management center, they go out, they've lost all their tolerance, which is lost within days, and then they go back to their usual opiate dose, and they die because they don't have any tolerance to it. So you shouldn't view opiate withdrawal as benign. Treatment of opiate withdrawal, we'll talk about these two options, buprenorphine and clonidine. Buprenorphine is a sublingual preparation. It has no or very minimal oral bioavailability, and it is a partial opiate agonist. So it attaches to the receptor and activates it, but not fully, which means it has a ceiling effect, and clinically it's very hard to overdose on buprenorphine. So its overdose risk is much less than methadone, and it's less than potent opiates that you prescribe all the time, morphine, oxycodone, and hydromorphone, and fentanyl. So it binds very, very tightly to the receptors and dissociates very slowly from them. So what that means is its duration of action is 24 hours or longer, which makes it ideal as a long-term treatment for opiate addiction. And it will displace opiates that are already on the receptor, except for fentanyl. Fentanyl has a stronger affinity than buprenorphine, but the other opiates, if a patient takes heroin and then they take buprenorphine, the buprenorphine will push the heroin off the receptor and they will go into withdrawal what we call precipitated withdrawal. So the trickiest thing about buprenorphine is starting it. The patient has to be in withdrawal with a presumed zero serum level of opiate and have a time interval of at least 12 hours from their last dose before you can safely give buprenorphine. So I talk about that. You can use a standardized scale called the Clinical Opiate Withdrawal Scale, or COWS, which will tell you the severity of the withdrawal, and a COWS score of 12 or more indicates that it's safe to give buprenorphine. So this is a copy of the COWS scale, and we have a handout here which contains the whole protocol for managing opiate withdrawal, the dosing and the indications, et cetera, and you can pick that up on the way out, and we hope that it will soon be on the emergency department website, so you can get access to it right from the computer in the emergency department. So the initial dose is 4 milligrams. It takes a couple of minutes to dissolve, and then you reassess in a couple of hours, and if the patient's better but not much, you can give an additional 4 milligrams, total of 12 milligrams on the first day, or if you can send the patient home with a script. And what we're recommending is that buprenorphine not just be a treatment for acute withdrawal, which it is, it's a good treatment, but also the first step towards long-term recovery. So we're suggesting a bridging script for patients who have been given buprenorphine in Emerge for a few days until the patient can be seen in the rapid access clinic. And there is a rapid access clinic run by Dr. Lee once a week. So if a patient comes on Tuesdays, so if the patient comes in on Thursday, you'd give them a script for buprenorphine for 5 days from a local pharmacy, and that would be a bridging script daily dispensed. You're not giving them 5 days worth of buprenorphine. They have to go every day to the pharmacy to take it observed. Kind of like, it's like methadone in that respect. This is a sample prescription, 8 milligrams once a day, February 12th to 16th, dispensed daily observed. And you are allowed, all physicians are allowed to prescribe buprenorphine. You don't need a special license or anything like that. However, it is limited use. It's a limited use code, and then it's fully covered by ODB, and the codes are 437 and 438. And these are very wide kind of codes. 437 is the most common one. That means that the patient is either has failed at methadone or is at higher risk for methadone toxicity. That's because they're older, or because they're an alcohol user, or they are on benzodiazepines, or they have respiratory or liver impairment. We would suggest using a lot of caution in giving buprenorphine to methadone patients. Methadone has such a long half-life that if you give it to a patient after 12 hours, they're going to go into withdrawal. They need to wait at least 3 days and need to be in moderate to severe withdrawal before giving buprenorphine. So we would suggest that you don't just transfer patients from methadone to buprenorphine. If a methadone patient has to be admitted to hospital and they need something to ward off withdrawal and methadone isn't available, then we recommend long-acting morphine. This is just a summary of the difference between the two, buprenorphine and methadone. Methadone is probably, well, it is more effective than buprenorphine in the long term at retaining patients in treatment. That's not surprising because it is a very potent full mu agonist, so it relieves withdrawal symptoms for a full 24 hours more effectively than buprenorphine. But the overdose risk for methadone is very high. Every year in Ontario, about 150 people die from a methadone overdose. That's from prescribed by a doctor, which is still very, very high considering the smaller number of people who are on methadone. And you need a special license to prescribe methadone. That means you have to take a course offered by the Center for Addiction and Mental Health, and you have to pass the course and do an observership, and then you can prescribe it. And it's not really practical to use methadone for treatment of acute withdrawal. The CPSO has clarified their stance on buprenorphine training and prescribing. They do recommend training, in the same way that they recommend that anything that you do, any new medication or procedure or intervention, that you have the appropriate clinical skill and knowledge. But it's not mandatory, and they're not checking to see if you have the training. So what we're saying, in the emergency department setting, we're not asking emergency doctors to undertake the long-term management of opiate addiction. That does require considerable training and skill. All we're saying is that we want you to treat opiate withdrawal just as you're already treating alcohol and other withdrawal syndromes, and give the patient a few days until they can be available for definitive diagnosis and treatment. Clonidine is not as effective at symptom relief, and it's certainly not as effective as at retaining patients in treatment. And I should say that this has been confirmed in a very large randomized trial done in an emergency department setting in the States, in Boston, where they showed that patients who received buprenorphine in the eMERGE were much more likely to attend treatment a week later than patients who didn't. But if buprenorphine is not available or it's not indicated or whatever, you can use clonidine. It is an alternative, and these are the protocols: 0.1 milligram QID PRN, hold if the blood pressure is lower. Probably many of you are familiar with the clonidine protocol in any event. Discharging patients with an opiate use disorder, remember that if, let's say they're discharged and for whatever reason they're not on buprenorphine, you have to tell them that they are at risk for overdose because they've lost tolerance. And every year, last year in Ontario, 700 people died from an opiate overdose, most of them from prescription opiates. And so this is a very major public health problem. In some sections of Ontario, like Northern Ontario, there are more people dying from opiate overdose than from car accidents. So, it's partly up to us and the emergency department to address this. You want to tell the patient about overdose prevention strategies, which I'll get to in a minute. Refer them to this rapid access clinic, and give them naloxone, which I'm going to talk about, to take home. 1 or 2 vials of naloxone to take home. This is the referral card, and it is, we understand, currently available in the emergency department. And I'm not sure where it is, but it is there in your emergency departments. The Rapid Access Addiction Medicine Clinic. It's on 648 Huron Street, and it's open on Tuesdays. The patient should come earlier in the morning if possible. And so if you have a patient that you refer, and by the way, this is not just for opiate addiction, but for all addictions, including alcohol addiction, you give them the card. They don't need a formal appointment. You don't need to write a referral note. They go there and show the card, and they will be assessed by an addiction doctor. And buprenorphine, or for alcohol, anti-craving drugs will be put in. So it's now on the same model as any other disease. You see someone, you want to refer them to a cardiologist or to an endocrinologist or a general internist or whatever, then you make that referral. So it's the same model as that. Now, talking about opiate overdose, like I say, a serious public health problem, you need to recognize who's at risk. And these are the risk categories. Certainly patients who take opiates in a non-oral route are at higher risk, injecting or snorting or smoking. Recently abstinent opiate-addicted patients. So you see a patient who is in withdrawal management and they haven't used opiates in a week. That patient is at extremely high risk for overdose. Binge opiate users, those who kind of go for a day or a week or whatever without opiates and then they take a whole bunch. Patients on extremely high prescribed opiate doses, especially those over 400 milligrams of morphine equivalent per day. And patients who use opiates and benzodiazepines and alcohol. The use of benzodiazepines, we've all been taught that benzodiazepines are safe as an overdose risk, and that is true when used alone. But in combination with opiates, benzos will reduce the lethal dose by a factor of 5. They tremendously increase the lethality of opiates. So what do you say to the patients who are at high risk? Explain to them about tolerance. Say, if you go back to your usual opiate dose, that was fine, a few weeks ago, you could die. So don't inject. Take a much smaller dose. In fact, take a test dose. Lots of times now on the street, drugs are mislabeled. They'll be called OxyContin, but they really contain fentanyl. Fentanyl is like the deadliest drug. It's even worse than heroin because it acts so fast and it's so potent. With most overdoses, the patient has some time. They kind of fall asleep and drowsy and so on. With fentanyl, they can die, they can collapse and die very, very quickly. So we advise a test dose. Don't trust anything in terms of what the dealer says is in the drug. Don't mix opiates with alcohol and benzos. And this is really important. Never use alone. Most of the opiate deaths have been because somebody uses alone, they fall asleep, and they don't wake up. They must use with a friend who, if they get into trouble, will be able to intervene and call 911. And we also need to warn patients about what an opiate overdose is like. So lots of times the patient is drowsy and nodding off and slurred speech, but they're able to engage in conversation. So the friend says, okay, they're fine, and just leave them alone to sleep it off, and the patient dies. You have to tell them that they have had a fatal overdose. Even if they're able to engage in conversation, that keeps them alert. Their reticular activating system is going when they're talking to someone. It's when they fall asleep that they lose consciousness and they die. So if they stay with them. If they can't be woken up fully, call 911 and start chest compressions. We don't advise doing the respiratory, the breathing, simply because it's too complicated for most patients, and then give them naloxone. But the most important thing, even more important than naloxone, is to get these patients into treatment and to send them to the rapid access clinic. So take-home naloxone. This is an example of a kit. Oh, shoot, sorry. That we've prepared. And it is going to be distributed, but it's not yet available in the London emergencies. So the kit contains 2 vials of 0.4 milligrams naloxone, 2 syringes, alcohol swabs, and an instruction on how to do it, that you inject it into the arm or leg and so on. And it's been shown, there's very good observational studies that this works in the States, that it actually does reduce overdose death. It feels uncomfortable for some emergency doctors because they're giving a parenteral medication to a drug user, but this is not obviously a drug of abuse. This is the opposite of a drug of abuse, naloxone. And also it feels funny because it's going to be used not on the patient probably, but on someone else, the patient's friends. That's usually how it works. So you should view it as a rescue medication, kind of like the EpiPen. And we know that the EpiPen can be given, a camp counselor has an EpiPen and gives it to someone else that's not your patient. So we feel it's a very extremely safe and effective harm reduction strategy. This is again the contents of the naloxone kit. And this is a little pamphlet for the patient on how to administer naloxone. Okay, so that's that. We'll go into a few other complications and problems with opiate use disorders, and we should have lots of time for questions. Psychiatry, I think it's common, certainly in Toronto, for a patient who is addicted to opiates to be referred to a psychiatrist, and that is often important. But we would say that they don't need an urgent psychiatric inpatient consult with psychiatry unless they're at imminent risk of harm, that is, unless they express active suicidal ideation. Infections outpatient treatment, as you know, this is very, very common, and you will use, it's the same protocol as any other infection, oral antibiotics that cover staph and strep, but you should consider, of course, injection drug use as a cause for the cellulitis or abscess and offer treatment with buprenorphine. If the patient isn't in withdrawal when you talk about buprenorphine, then they can go to withdrawal management or go home and come back or just go directly to the rapid access clinic because you don't necessarily want them waiting around for 12 hours until you can give them the buprenorphine. And so what we're trying to say is that you're not just treating the acute infection or the acute presenting complaint. You're saying what's the cause of this? The underlying cause is their opiate addiction, and you want to start the conversation about initiating treatment for that when they're in the emergency department. You can avoid PICC lines clearly in this kind of population if possible. You can always get a telephone or even an in-person consult from the RAM physician, which is Dr. Ken Lee and his colleagues. He's very available for that, and he does do consults even now. Musculoskeletal injuries and trauma. And it's certainly in Toronto, there are some emergency departments that routinely use Percocet or hydromorphone dilaudid for even minor injuries, muscle strains, contusions. And the evidence suggests that these injuries, in general, by and large, do not require opiate medication. And that NSAIDs and acetaminophen and all the other things that we do are at least as effective and certainly are safer. So we would discourage the use of potent opiates for minor injuries. If opiates are indicated for an injury or anything else, we recommend immediate release low-dose opiates above high-dose controlled release formulations. We were taught years ago that controlled release formulations are safer than immediate release and less addicting. That's actually false. It is kind of true if you have exactly the same dose, but controlled release opiates come in much higher dose formulations. Remember that codeine is effective for acute pain. If you do give an opiate prescription, only do it for a few days. There's no role for fentanyl in the treatment, the fentanyl patch in the treatment of acute pain. And don't prescribe benzos along with the opiates. Warn patients about not drinking and warn them not to drive. And send them back to the family doctor. For patients who are actually admitted with trauma, suspect opiate addiction, or anything else, if they're requesting much higher doses than would normally be needed for their degree of injury, if they request a specific opiate, if they demand their dose immediately, and if they have risk factors for addiction, and if they were on a high, unnecessarily high opiate dose prior to admission. Now, what about requests for refills? And this is common. The patient with chronic pain says his doctor is not available and is running out. You should contact the patient's pharmacy and check that the patient is telling the truth. If you do write a script, you can put on it, don't dispense if you receive an alert from the narcotic monitoring system. I don't know how many of you are familiar with the system. It was introduced about a year ago. So all prescriptions written in the province for opiates are put in a central registry, a computer, and the pharmacist sees them when the patient presents the script. Unfortunately, the doctor doesn't see them, which is a huge weakness in the system. So let's say you give a prescription for 30 Percocet tablets to a patient, and you ask the patient, when did you last have it? And he said, I got it a month ago from my doctor. And he goes to the pharmacy. The pharmacist will get an alert that says, well, no, you got it from Dr. Smith, 3 days ago. And so the patient lied to you. But the pharmacist is now stuck. Maybe they can't get hold of you. So what do? They can honor the prescription or not honor it. It's totally up to them. So it's kind of not a great system. It's better than it used to be. So what we suggest is on the script, for patients you don't know, just say, do not dispense if you receive an alert. And that allows the pharmacist to refuse the script. We want you to communicate with the family doctor, and you don't have to give the patient what the patient wants. The patient says, I'm on 100 micrograms of fentanyl and 10 Percocet a day for breakthrough and Ativan 1 milligram TID. You don't know the patient. You wouldn't be comfortable giving that prescription. You can give a much smaller script than that, and the patient is maybe uncomfortable with it, but you have to emphasize safety over patient comfort. And if they get mad, say, well, don't run out next time. So that's what we suggest. These are the morphine equivalent doses, and I think it's important for you to, this is the common currency, and this is the only way you can really understand and prescribe opiates safely, is to have a common currency, which is the morphine equivalent dose. So basically, in a nutshell, morphine is the standard dose. 1 milligram of oxycodone equals 1.5 milligrams of morphine. So oxycodone is 1.5 times more potent than morphine. And hydromorphone is 5 times more potent than morphine. So if you give a patient a prescription for hydromorphone 8 milligram tablets, that's equivalent to 40 milligrams of morphine. If you give them a prescription for 1 Percocet, that's 5 milligrams of oxycodone, is 7.5 milligrams of morphine. That's all you need to know, really. The fentanyl, you need to know that it's very, very potent. Even the basic dose of 25 micrograms is equivalent to 60 to 100 milligrams of morphine. So I think there's almost never a justification for prescribing a new prescription of fentanyl in the emergency department, no matter what the patient is on. Yeah, it's right. 60 to 100 milligrams of morphine is equivalent to the 25 microgram patch. Very, very potent.
Oh, okay.
Yeah.
Yeah, because if we give 25 mics IV, that's certainly not like, yeah. I was thinking of the IV.
Yeah, sorry, I was talking about outpatient. These are all oral except for the patch, which is transdermal. 72 hours
25
would be
microgram
25
patch
micrograms, yeah.
is going to deliver 60 to 100 milligrams of morphine over 72 hours.
Well, 60 to 100 milligrams of morphine a day, so 25 micrograms over 72 hours would be 60 to 100 milligrams of morphine a day over 3 days. So, yeah. So it's just to say that that's a pretty large dose, and there have been cases of death where a patient was on codeine and they were given fentanyl, or they were on morphine, but they weren't taking it regularly, and the emerg doc didn't know that and gave them fentanyl. And so we would just say, and I'm talking about outpatient, we'd just say there's no role for fentanyl in the emergency department. So drug seeking by patients with opiate use disorders, certainly the emergency department, primary care doctors are a source of opiates for patients, and it can be hard to diagnose because the patient is basically lying to the doctor. So how would you know? I think it's often when you see a pattern, right? The patient will target one emergency department and come repeatedly with the same complaint. They may make aggressive demands for a specific opiate. They're not going to accept non-opiate treatments. They may return to the same ED with the same complaint. They're often on high prescribed doses, yet run out early for various reasons, and they have risk factors for addiction. So obviously you're going to check it out and check with the pharmacy. What we're saying is that if you make a provisional diagnosis of opiate dependence and drug seeking, don't give them opiates. Just say, no, we're not going to. We have a better treatment for you, and that's buprenorphine. Now, the patient may say, no, I don't want it. How could you accuse me of that? That's okay. You've made a diagnosis. You made it in good faith. You feel it's true. And you're going to say to the patient, if I give you hydromorphone, it's just like me giving alcohol to an alcoholic. I'm not going to do it. It's going to make you worse. It puts you at risk for harm, and I won't do it. And I think the bottom line with drug-seeking or manipulative or angry patients is always the same. You got to do what's right for the patient, what's the safest thing to do, even if they object. So you say, no, I think you're addicted. I'm not giving you this medication. I've offered you a safe alternative. You don't want it. That's your choice. And then you should inform the family doctor. And because lots of times, this is a good thing for the patient, because when their sources of opiate runs out, they will say, finally, okay, that's it, I'm going to try treatment, because they have no other choice. Depression and suicidal ideation, well, you're going to manage it as you would any other. Some of these patients, if they have an active plan or if they've attempted suicide, will be admitted. But remember that suicidal ideation is extremely common in opiate-addicted patients or alcohol-addicted patients or their addictions. And what you have to tell them is that their mood will rapidly improve with treatment. So you should offer them buprenorphine either in the emerge or on an inpatient basis or outpatient. Just say that part of the reason why your mood is so low is that you're going through withdrawal every day. The high doses of opiates induces a depression, and your life is all messed up because you're spending all your time and money taking drugs. So we talked about that. I'm not going to go into this too much, managing pain in emergency department patients on methadone and buprenorphine, other than to say that if they are on a stable dose of methadone or buprenorphine, they have a considerable degree of tolerance to the analgesic effects of these drugs, and so they may require opiates for a severe injury like a fracture. So if they're on methadone and they've been on a dose of methadone for 10 years and they come in with a fracture, they probably will need short-acting opiates on top of it. In fact, even higher doses than before because they have some degree of hyperalgesia. Treating acute pain is not going to trigger a relapse, and the patient isn't necessarily drug-seeking. So that's just that. Again, all these protocols are in these, we have 7 protocols that are going to be put as PDFs on the emergency department web so you can go over them in more detail afterwards. And we have an example of one that we can distribute at the end. So some resources. So buprenorphine is currently available on the formulary in the emergency department in London, in the London Academic Health Sciences Centre. So you can order it. Naloxone has not yet been approved. It's currently under review. But the Public Health Department has agreed to hand out naloxone kits along with patient education in the Rapid Access Clinic. But we would like them to actually be available with the prepared kits in the emergency department, but we haven't worked that out yet. CWAB protocols, that's the protocol for managing alcohol withdrawal, is already in use. And the clinical tools, although they're not, we don't think they're available on the ED intranet yet, but they are available on the Medify website. So if you're interested, you just go to Medify Portico. It's a long explanation, and then you'll get the toolkits. These are the 7 toolkits that are going to be on the emergency department website. So it's alcohol intoxication, withdrawal, alcohol-related presentations, opiate overdose, opiate withdrawal, opiate-related presentations, and opiate inpatient management of the opiate-addicted patient. So we have some case scenarios, but first of all, any questions or comments about the management of opiate? Yes?
I wondered if you could comment on the use of that drug.
Naltrexone is a competitive opiate antagonist, so it binds to the mu receptor. So it's in the same class as naloxone, which is also a competitive opiate antagonist, but it's an oral tablet, whereas naloxone has no oral bioavailability, and its duration of action is 2 days. Interestingly, its main use is for treating alcohol dependence, because alcohol is associated with a euphoria. When people drink, they are euphoric, and that's partly because there's an release of endogenous endorphins, which is genetically determined, so that people get a buzz when they drink because of these endorphins. And naltrexone blocks the attachment of the endorphins to the mu receptor, so it blunts the patient's euphoric effect. So it's been shown to be effective in reducing binge drinking and craving. So it's a good medication, very safe. Obviously, the main contraindication is if they're on opiates, it would trigger severe withdrawal. Unfortunately, it's only available now under exceptional access, and that's a terrible problem, and it's not used very much in Ontario. We've been lobbying, and we just recently submitted a report to try and get ODB to put it as a general benefit, but right now it's not available. It's not as good for treating opiate addiction, but there's a new product called Vivitrol that will probably be on the market in a year or 2. Vivitrol is a long-acting depot preparation of naltrexone, so it's only, I think, once a month. So it will probably be, it will be better for alcohol dependence, and also a treatment for opiate addiction. So the patient who's fully abstinent, if they have naltrexone on board and they take an opiate, they're going to feel nothing. They won't get sick or anything. It'll just have no effect. Yes.
People's information about a week ago, or last Friday, Health Canada announced its intention to make naloxone an over-the-counter medication as opposed to prescription medication, so
Yes.
it could be available. So that's new. And the question that I have is, what's the sort of the word on the street amongst addicts with respect to buprenorphine and its effects? Are people resistant to taking it, or do they shy away from it, or what's the attitude sort of?
I think the attitude, so two questions. One is about Health Canada has now converted naloxone from a prescription drug to a non-prescription drug status, which means it can be available in pharmacies without a prescription or distributed by nurses, etc. That's a good thing. I think it's not enough because we believe it should be covered under our Ontario drug benefits because we don't think that injection drug users are going to go to a pharmacy and buy it. We think it needs to be distributed at the point where they need it the most, which is in primary care offices or emergency departments. Right now it's distributed for free through public health, but it's still only reaching a very small number of people who would need it. But it's a good start what Health Canada did. The next question is, what's the word on the street about buprenorphine? The first is that drug users like it because it has less stigma than methadone. Eventually, of course, it will have the same stigma once it becomes well known. But right now, for patients who are on methadone, they have to line up at pharmacies and they have to go every day. And so other people kind of, say, oh, there's another methadone addict. Buprenorphine doesn't carry that stigma. The other good thing about buprenorphine is that it can be prescribed more flexibly than methadone because it has such a lower risk of overdose. You can give patients take-home doses if they require them for work or school or family responsibilities, whereas methadone is a very dangerous drug, high risk of overdose. Patients have to go every day observed for 2 months, regardless of their social circumstances. The drawback to buprenorphine, though, and this is what makes patients afraid, is that they have to be in withdrawal or not take opiates for at least 12 hours. So that worries some patients. Any other questions? Yes?
You mentioned the use code, but would you be able to comment on the price of buprenorphine, whether it be to the patient or the system?
Buprenorphine is way more expensive than methadone right now. Even the generic buprenorphine is pretty expensive. I think it's about $7 for a 8 milligram tablet, whereas methadone is pennies. Now, methadone is still a very expensive drug to distribute because it has to be prepared in individual bottles, and the pharmacy charges the government $6 a day for every day of methadone treatment. So that's kind of compensates a bit for the cost, but it's not cheap. And we're kind of surprised that the cost didn't go down more with the generic buprenorphine, but that's just the way it is. Yes?
So let's say we have a patient in our outside the 12-hour window and potentially demonstrating some signs of early withdrawal. Are there any head-to-head trials comparing just temporizing his withdrawal with clonidine over the next 48 hours or 5 days, to using Suboxone in terms of relapse rates and longevity and all that kind of stuff? Or
there have been several trials that have compared buprenorphine to clonidine and that have shown that buprenorphine has has better symptom relief. So clonidine is pretty good for the physical symptoms of withdrawal, that is the piloerection, the nausea, the abdominal cramps, and so on. But it doesn't do much for the psyche, which is the worst part of withdrawal, the anxiety and the drug craving and dysphoria and insomnia. Head-to-head, symptom relief, buprenorphine does a lot better. Also a lot better in treatment retention. And at St. Joe's in Toronto, they use it routinely in the Emerge, and the Emerge docs love it. In fact, we tried to arrange a trial, head-to-head trial there, and they said, no, we like buprenorphine better. And the reason why is patients take it and they say, I feel normal. They don't get stoned because it's got such a slow onset of action. They say, I feel normal, and then they go to the rapid access clinic to get an ongoing script. So I would say really the evidence is pretty clear that it is superior to clonidine. But again, If you have a patient who isn't in withdrawal or who says, no, I don't want any opiates, then clonidine is still a good alternative. Yes?
So what period of time, let's say you prescribe the buprenorphine from Emerge and they go to the rapid access clinic, over what period of time does the typical person get weaned off of the medication? How long does it take them to be drug-free?
That's a good question. Basically, it can be as quickly as the patient wants, but what we know is that it works a lot better the longer a patient has been on it, the longer a period between their last drug use and now, the longer period of abstinence from drugs, the more social support they have, the presence of active. So the ideal candidate has been on buprenorphine for a year and is employed or in school, has supportive family, doesn't hang out with drug users anymore. They do a lot better. And the reason why is that even with buprenorphine, even with slow tapering, there will be a mild withdrawal. And patients who the last use of heroin was 2 weeks ago, if they're tapered then and they get the withdrawal, their immediate reaction will be to get the drug again. Whereas if they have a lot to lose and they got social supports and other ways of coping with anxiety and they don't even know how to get hold of a drug user, it's a lot better bet for tapering.
Buprenorphine with marijuana addiction? Like there's some people who are pretty severely addicted to marijuana.
Yes.
And that's their primary drug of choice they want to get off. Is there any evidence?
No, and pharmacologically it wouldn't really work because they're totally different receptors, but there is emerging evidence that Sesame is a good treatment for cannabis addiction. Cannabis is associated with a withdrawal, like heavy daily users do experience withdrawal. It's kind of like smoking withdrawal. It's anxiety, severe anxiety and craving and insomnia and weakness and so on. But nabilone, which is Sesame, has been shown to reduce, to blunt the cravings and to blunt use. So that's what we use, along with counseling and psychosocial support. I think we're seeing more and more cannabis addiction because it's, so our society is so pro-cannabis, it's easily available, it's not very expensive, and it's very potent. Yes?
To give buprenorphine, they're not supposed to have taken opioids within the previous 12 hours.
Yes.
What happens if they're not truthful about that, or they're what are the consequences if they have in fact taken them, or if we prescribe buprenorphine, they go home and they take their opiates anyway?
Yeah. So very good question. So the patient should not only have said that they haven't used for 12 hours, but actually to be in at least mild, if not moderate withdrawal, as determined by the COWS scale. And the COWS would be done by the nurse, it's not done by the doctor. And so what I tell patients is, you should be truthful, because if you take it too early, you will feel sick. And they want to get on with treatment, they're feeling terrible, and they say, look, you may have to wait longer, otherwise you're going to be sick. If they take the buprenorphine and they get precipitated withdrawal, in general, it's no big deal, except with methadone. That is terrible, horrible withdrawal. But with other drugs, it's no big deal. They just feel even worse, and they're nauseated. And all you can do is kind of tell them to wait it out and give gravel and so on. The big problem is they'll never take buprenorphine again, because they've taken it, they felt worse, and they said, no way. You can explain to them till you're blue in the face that it's precipitated withdrawal. They just will feel it's a bad drug for them. So it's kind of like then you've lost your one chance for a good therapeutic intervention. Yes?
I wondered if there's plans to make the rapid access clinic more often than once a week.
And we're going to talk with Dr. Lee about that. I think probably, and it will depend in part on demand. So the rapid access clinic is going to get patients not only from emergency department, but from nearby withdrawal management centers, and even from primary care doctors' offices. So it's not a walk-in clinic for the general public. It's a preferred pathway for patients already in the ED, withdrawal management, hospital, or primary care. And if they get enough patients and they get busy enough, then I'm sure they'll expand it. So it's just, most of the places, we also have this going in Ottawa and Sarnia and St. Catharines, Sudbury, and Newmarket, and I'm forgetting a place. Oh, and Sound, yes. And they usually have it twice a week. I think one place has it 3 times a week. So it's all variable. But I think here they'll start off with once a week, which does enter into your calculations. If a patient is there on Wednesday, you would need to give them a 6-day script of buprenorphine. Yes?
First, and then tell them to wait a few hours to make sure they've had a significant withdrawal period to cover them, and then tell them to take it like
Absolutely, that's a great idea. In fact, there was a case I was just talking about of a patient who was presented here. He had sought methadone treatment and wanted to go on Suboxone. He was going to go on to a rapid access clinic, or no, to a Suboxone clinic the next day. And he was here in emergency feeling somewhat unwell, but it had only been 2 days. So the doctor quite appropriately gave him clonidine just to relieve his mild withdrawal symptoms, because if he had given him buprenorphine, he might have precipitated a severe withdrawal. So clonidine is a good idea for if you're not sure that they should or that they can safely take buprenorphine, you can give them clonidine instead. That's true. And, sure.
So people know how this has been progressing. Dr. Kahan and Dr. Lee approached me about a year ago, like last January, about the Arctic project that Dr. Kahan and his colleagues are working on. And Dr. Ken Lee set up this clinic, which I think he started about 2 to 3 months ago. So it's only recently available, and it's for both narcotic and alcohol withdrawal. So you can send either to it. Going on at the same time is an ethics application, because this is part of an Arctic research grant that Sarah and myself and Melanie have been working on. Resubmitted to ethics for the 3rd time, even though it's been approved by 2 other ethics boards in the province. It's resubmitted for the 3rd time last week. So hopefully that piece will help us roll it out as well as a research project, where you'll be able to do a survey, the patient can do a survey, and the family doctor does a survey. We were able to get Suboxone on formulary as part of this project last July, so it's been available. We just haven't advertised it because we haven't had the opportunity to have this type of an education session about it, but it's there. And the tools that Dr. Kahan mentioned, I have basically the PDF sitting in my email inbox ready to send out to everybody to review at your leisure, as well as we'll post them on Fred, which is our online repository of sort of information, and on EM London. The naloxone kits we'll discuss at the department meeting today. This has kind of been let's call it a snowball. A year ago, I think if you presented to this group about giving naloxone kits at home, there would have been some jaw-dropping. In fact, even our base hospital or EMS system would have been against our primary care paramedics giving it without phoning a physician, whereas it's exploded. Now, as Ahmed said, Health Canada is talking about having it as will have it as over the counter. It's available at the health unit and at CAMH currently. What Julia or the operational leaders and myself are trying to work out is the education associated with giving out the naloxone kit. As we try and move people through our emergency department, we don't want our docs to have to spend 15 minutes talking to a person about how to use a naloxone kit, so we want the resources available to educate the patient without the physician having to give all that instruction. So that's sort of the main topic for discussion. But again, we're going to talk about the kits at the department meeting today.
Yeah. That's very good, and that's a great summary. What we say to public health and to other people is that it's much better to give naloxone when the patient is in the emergency department, even if they get kind of minimal information, than to not give it at all. And the public health model is the patient has to come, make an appointment, go to the public health department and get like 45 minutes of education. Sure, that's great, but they're not getting it to the people who really need it. And in terms of education, I think that it's in the pamphlet, in the toolkit, and you can emphasize just a few main points. You've lost tolerance, you're at high risk. Use a very small or even a test dose of opiates. Don't mix with alcohol and benzos. Never use alone. And that's kind of it. And then the instruction about how to use it is your friend, you can't wake up your friend, you call 911, you start chest compressions, you inject a full vial into an arm or a leg, and then you inject again in a few minutes if the patient doesn't respond. So it's minimal, but I think patients get it. And there is no medication in the world, sorry to say this, that says cost effective where the risks are so pretty well zero compared to the benefit. The worst you can do with naloxone is, I guess, give it to someone who doesn't need it, who is opiate dependent. They're going to go through withdrawal and feel miserable for 15, 20 minutes, and gradually they'll be better. And they'll be really mad, but nothing bad's going to happen. So if you give it to someone who isn't opiate dependent, there's zero effect. And it saves lives. It's been shown to save lives. Not only has it been shown to save lives by giving naloxone, but it makes the drug user more aware of these messages, like how to avoid overdose in the first place. And in my patients, every single one of my patients has lost a friend to an overdose. So they're aware. Yes?
Naloxone in the kids?
0.4 milligrams. Now, I know that may not be enough. So there's 2 vials. Especially with fentanyl, 0.4 milligrams doesn't seem to be enough. They often need 2, but hopefully by then the paramedics will arrive. Yes?
I'm a bit confused about a patient who's on a stable dose of Suboxone, because I think you said that buprenorphine has got a higher affinity for opiate receptors than most opiates.
Yes.
So if someone's on a stable dose, is their tolerance down, or will they need more opiate in order to, if they start to use again while they're on Suboxone?
So yeah, that was another part of your point. So if you give buprenorphine to someone who has just taken heroin, they'll go into withdrawal. But if they're on buprenorphine and they take heroin, nothing bad is going to happen. The buprenorphine will block, but probably not completely, the attachment of the heroin to the brain cells. So they'll still get a buzz if they use enough, but it will be blunted. They would need a higher dose of heroin or other opiates. So you could, in fact, give buprenorphine. A patient is in hospital and they need extra opiates on top of their buprenorphine because of a serious injury or surgery. Yeah, go ahead and give the opiate, but you may need to give them a higher dose to overcome the buprenorphine blockade. Yes?
This question a little bit for Adam too, and I think this is a great initiative. It would be a great add-on to what we do for people, which is sometimes not enough, or many times. Our usual referral resources are Thames Valley Addiction Center. That's what I think most of us have sent people. And then the urgent psychiatric outpatient clinic, we send people even though they say we can't treat you if you have an addiction. So usually how are those 2 resources, are they aware of the rapid access clinic, and are they referring people back and forth, and how does Thames Valley Addiction fit in there?
So Ken has worked with CAMH as well as Thames Valley Addiction, so they're all linked together, so they're aware of it, and there's no concerns there. So it's an extra resource, or really a new good resources. As you identified, Amit, right now we don't know much of anything for a lot of these patients, unfortunately, because we haven't had much available to do for them as terms of follow-up. So
I just have a quick question about flow.
Yeah.
So if we're planning to start Suboxone on someone and they come in and they're not really withdrawing yet, or it's mild, and they last used 6 hours ago, do we keep them in Emerge for 6 hours until they're in moderate withdrawal and then start it? Is that the plan?
Personally, I wouldn't. I would send them to the clinic for their management, depending on the timing, to the clinic, and maybe with some clonidine.
And the clinic is the one that's only on once a week?
And Ken Lee is perfectly prepared to increase the frequency of the clinic, thanks, I think it was Don that asked that question, based on referrals. So, I mean, we're going to be one of the biggest referral base, if not the biggest referral base. He's actually in Hong Kong right now, back in a couple weeks, with someone covering him. But as we refer, he'll increase the clinic frequency.
Sorry, do they just walk in on a Tuesday morning?
8:30 in the morning. There's a card we give them that will be available. Yep.
I was just thinking about that, about what Mel said about the alert about the narcotic monitoring system, and I'm wondering what would be the downside to us just adding that to our template for every narcotic prescription that we fill out? Is there any potential downside to that? Because that would pick up the people that we are not even suspicious are there sort of drugs.
Great idea. Let's do it. We'll do it.
You want me to do it?
Just remind me by email and it'll get done. Lisa?
Availability at St. Joe's?
I don't think it's available at St. Joe's currently, but we'll check. Okay. Can you email me?
I think that would be a good idea.
So Thank you very much, Dr. Kahan, for coming in. I failed to do a formal introduction other than he's from Toronto. Dr. Kahan is the director of the Substance Use and Disorder Service at Women's College, so obviously has the experience and has well published in this area. And the project he's been talking about sort of a few different times throughout the presentation is called MEDIFY. And MEDIFY stands for Mentoring Education and Clinical Tools for Addiction Primary Care Hospital Integration Project. So he's got a large national grant. ARDIC is a hugely respected granting association, and I'm super happy to be associated with it as a site and as a group of physicians.